Good afternoon. Welcome to the Physician Querying, Being Successful and Compliant. Our speaker today is Gloryanne Bryant, an AHIMA ICD-10 CMPCS approved trainer with over 35 years of HIM experience. We will have a question section at the end of the webinar. Please enter your questions in the box at the left of your screen. Please make sure that your questions asked are based on the content of the webinar. I'll now turn the call over to our speaker, Gloryanne Bryant.
Thank you, and welcome everyone. Happy spring. Hopefully you're getting signs of spring in your area of the country. We have a large group on the call today, so we're excited to be here. I thank you for joining us, and I have a brief disclaimer on your slide presentation. Just want to be sure you are aware that this is an educational, of course, presentation in its format and content, and we have quite a bit to cover, and I'm sure you'll have some questions, so we will get right into our goals and objectives. So for today, we will be looking at the history of the query guidance that has been in place over many years, actually. When you see this history, you can see it goes back quite a ways. And with my involvement in the industry, I was very much at the very beginning of some of this activity. And then we'll move into understanding some of the key risks and vulnerabilities in our area of coding and documentation. Then we'll look at some of the guidances within the query practice brief, the AHA coding clinic, and improvements and things you can be doing and watching out for in your querying practices. Yes, there we go. I'll be moving back and forth on the keyboard to advance the slide, so you may see a slight delay. Well, it's well known and accepted that the physician query process is essential to coding, and certainly without that, clinical documentation. And we have a lot of CDI activities, clinical documentation improvement activities out there in the industry too. The history of the physician query really needs to go back more than 30 years. Now, in HIM and coding, it's been part of the process of checking on and clarifying things for a number of years, but particularly, it really started emphasizing it with the diagnostic-related groups, or DRGs, and back in 83, 84, when all that started. So now, for a number of years, there would be verbal querying, maybe some notes, even people were using sticky notes, or yellow Post-it notes on charts to query. We were all paper back then. And as years went by in the early 1990s, forms were started to be created, and there was concerns with upcoding and leading physicians to say a particular thing on a query response. And 1998, 2000, upcoding and ONG investigations were going on. And in 2001, CMS was very alarmed at some of the things they were seeing in their reviews, including sticky notes that I actually saw a couple of them. They were quite leading, such as, please document dehydration, as this will get us $3,000 more in reimbursement, and those kinds of leading things. And there was no standard or format. So there was a brief halt in using queries for the review process, the scrutiny of the regulatory folks. They wouldn't accept them. But after having a town hall meeting back in Baltimore, meeting with CMS, it was decided that, yes, we could have query forms used in the chart, and they could be used to validate the coding accuracy and improve documentation if they followed some particular rules. So back then, we had peer review organizations, now QIOs that we recognize, and they were the ones doing the reviews. And so the instruction was given to them to, yes, they can accept the query forms in the medical records, but they need to make sure that the query forms are clear and concise, precise language, presenting the facts and identifying, present a scenario. And right at that time, AHIMA was working on a practice brief, the first of many practice briefs, and that was in 2001 where the first one came out. This is a screenshot on your left and some verbiage from the beginning of that practice brief from 2001, talking about the principles of medical record documentation. And some of that is really relevant even today that we recognize that the medical record has a multitude of purposes, and it serves as a communication between the clinicians, the providers, the healthcare team. It serves as the basis for evaluating the adequacy and appropriateness of patient care, protecting legal interests of the patient, the healthcare providers, and even facilities and practices. And it provides for clinical data for research and education. So yes, a lot of valuable use of the medical record documentation, even back in 2001 and certainly today as well as we look more at quality. Between 2001 and 2008, that practice brief was in place, and we were doing a better job, but it was recognized that we could do more things, especially with the emergence of CDI, or Clinical Documentation Improvement Programs, and staff dedicated for that function to be done on a concurrent basis, primarily in the hospital setting. And with that, in 2008, a practice brief was again put out to the industry by AHIMA, managing the physician query process. And this had a lot more information. It addressed some of the scrutiny, the compliance issues that were there. It presented scenarios and so on. So that's another source historically for the different practice briefs that we've seen. And here's some language directly from that practice brief, talking about our healthcare environments changing. A query is defined as a question posed to a provider to address additional clarifying documentation to improve the specificity and completeness of the data used to assign the diagnosis procedure codes in the health record, and documentation can be greatly improved by a properly functioning query process. Very true today as well, is it not? Then, continuing down our historical road, we saw in May of 2010, AHIMA put out a practice brief regarding the guidance of CDI programs. Because of that strong emergence that I was mentioning, we saw more formalized programs being put together. And in large healthcare organizations in particular, we saw these with teams of staff. They would sometimes be HIM professionals. They could have been nursing staff, and so on. These were used to help with the implementation of CDI on a concurrent basis while the patient was in the hospital. Now, that guidance is available and can be looked at, but there's been additional, of course, other information published out there, including toolkits and so on. So continuing, we come up to 2013 with a revision to the guidance for achieving compliant query practice and process. And here we talk about more about the communication and give a whole series of examples in this practice brief. And this one was pretty, I don't want to say earth-shaking, but was pretty much a big news item in our industry. And it opens up by talking about leading and the process of leading, because that became more and more, how do we query without leading? And if you think about the process of an attorney in a court of law, which it talks about here, and how that attorney can't lead the witness to a particular statement or answer, we can't lead a particular provider to a particular statement or answer as well. They need to come to that conclusion of a diagnosis or procedure information on their own. We can provide some other relevant information to them to help them understand the situation. So this communication and clarification is to get the goal of accurate code assignment, ultimately, to reflect the diagnosis or procedure of that patient. It's a true reflection of the patient's episode of care. With that, we saw, of course, as we all know, in October of 2015, we saw ICD-10. So there needed to be a revision made in the practice brief from 2013, updated in 2016, to reflect ICD-10. So the practice brief from 2013 was updated, and the only change in this version from 2016 was the use in the language around ICD-10. The remaining information was the same. It's still considered today to be an industry gold standard. We should be utilizing and following this practice brief to help us with our query processes, whether it be CDI, whether it be that of a coding professional doing the querying also. One of the main questions we typically hear is, well, when do we query? And the guidance tells us that whenever there is conflicting, imprecise, incomplete, illegible, ambiguous, or inconsistent documentation in that health record, that we should query. If the documentation describes or is associated with clinical indicators without a definitive relationship to an underlying diagnosis, we should query. If the documentation includes clinical indicators, diagnostic evaluation, and/or treatment not related to a specific condition or procedure, we should be querying. If the documentation provides a diagnosis without underlying clinical validation, we should query. And if the documentation is unclear for present on admission indicator assignment, we should query. And certainly the last one is reflective of the inpatient setting. Now, currently, AHIMA is working on a physician office practice brief for querying, and it will have some slight differences, removing the POA, for example, but you should watch for this to be released later this year, probably after July, August timeframe. And this will, again, help in the setting of a physician office, which can be different from, of course, our inpatient hospital setting and medical record and how we document. I want to go back to that leading piece because that's the biggest concern we see from a compliance perspective in the query process and in querying. The query must not be leading. It can't imply or give an expected answer to the question being asked. And some examples are those you see here. Some simple ones was the patient's chest pain caused by angina. Very leading. You're giving angina as your answer to your question. Was the patient on Lasix to treat CHF? Directly correlation, medication to a condition. It may seem logical, but we need other alternatives there because that's leading to a single choice. And then the patient was dehydrated, right? Correct? Again, leading. So caution should be used in our wording, and this is true for both written and verbal. This comes up a lot, too, the verbal querying, well, I was on the floor or I called up the doctor and I was discussing the case, needs to be following the practice brief guidance, the non-leading. It still needs to be that way. And creating that query and knowing when to query can be difficult or complicated, and there are a number of education and training techniques that prove successful for coding professionals and or CDI professionals when trying to improve upon query practices. But the biggest concern remains that leading piece and being and able to have the skills to have non-leading queries and result with getting the true picture of the patient care with that answer to that query, and that's the ultimate goal. I often get the question, too, and this comes sometimes from leadership, management. Well, is there really a problem with any of this clinical documentation? How big of a problem is it? So I did some research some time ago, and so these facts may be a little older now, but I think there's still something to think about. In this particular published report, they had 1.2 billion, we do in the United States have 1.2 billion outpatient physician office visits. And the research was showing that between 10 and 70% of the medical record contained documentation that was poor quality. So that's an average of 45% of the time. Therefore, if you think about the physician encounters, that's 500 million of them have poor quality clinical documentation. Now think about that impact. We're not getting a true picture of what the patient's illness or the illness burden, severity of illness, risk of mortality. It could be that we're leaving out information regarding medication, past medical history, so that poor quality clinical documentation can impact even that medical decision making. And we want to remember and keep in our minds that it's the patient. That's who we care about, and that's who we want to make sure the documentation is true. Another study that I thought would be of interest to you all today, since we have a great crowd today, that this study showed that it reported concurrent query rates were between 10 and 24%, and another 22% of organizations reported that their concurrent query rates were between 25 and 35. Now, that's something to look at, and this study was published in the Journal of Bone and Joint Surgery. Have you ever done a sampling of records to see, well, what's the average? And the sampling needs to be pretty significant. I can recall back in 2000, 2003, through that 3-year period, I was involved with a lot of reviews, both concurrent and retrospective, and we had a statistic of about 5,000 inpatient records, and we were able to identify this team. I think it was about 5 to 6 of us looking at records and keeping track of information. 29 to 30% of the time, the query would have been helpful, and this was very specific to diagnosis. Now, not all the times did that query, 29 to 30% of the time, result in any monetary results at all, but the query did provide a truer reflection of the patient care for the encounter, and that is really important, as you all will agree. So next piece I want to tie together to this talk today is this piece about we're under a lot more scrutiny, and there's concern for improper payments. The ongoing government reviews, they still continue, and this particular report, which I know the 2017 one came out just a short time ago, but I wanted to show you the 2016, and you can Google this report. It is free. You can locate it, put in your search engine Medicare Fee-for-Service 2016 Improper Payments Report, and you can download this payment report as well. And if you change the date and put Medicare Fee-for-Service 2017, you'll get the most recent one that was just released. This shows you where there is a lot of problems with documentation. Some of it you may have even heard about in the news, that there's improper payments in certain areas, and it shows you the dollar value of those, the rate of error in payment, and it also talks about the types of errors. No documentation, insignificant documentation, incorrect coding, medical necessity issues. So this might be of value for you to download and take a look at too, particularly if you're looking at annually where I would like to focus my attention. Another important report out there in the government, and this one I find a lot of folks aren't aware of, this Medicare payment accuracy, and it's under the paymentaccuracy.gov website. And it lists all the government, so there's not just healthcare, there are other areas, but it's all government, federally funded programs, and their payment accuracy. There's a section in there on healthcare, and it does break down details regarding different areas of healthcare, such as Medicare and Medicare Part C. So this might be a report, or go to that website, I should say, rather than a report. Go to the website and take a look at that. They do identify documentation that is not available to support the payment that was provided. And interesting, when you drill down in some of these hyperlinks that are listed there, this particular one I found very interesting for those of you who work in the Medicare Advantage HCC area. They do have some statistics, and they are monitoring and tracking improper payments in this area. And you can see from the slide on the screen right now the information and improper payments in dollars, and what they're estimating is improper payment rate of 8.3%. Now, you think about total dollars, and 8% sounds little, but when you put those financial dollars in healthcare up with 8%, it's a lot of money. So we want to be sure to keep track of these areas of scrutiny, and I was able to even go to additional hyperlink, and it drills down this particular one for the Medicare Part C under HHS. For those of you who are doing the HCC area, these 10 categories are being focused on as risk areas for documentation and coding. So you want to take a peek at the list of 10, and maybe we need to be querying more often or more specifically in these areas to diminish, of course, risk that could be out there with our HCC documentation and coding. So do we really need to query? Well, we've got some studies and reports that are telling us yes. We've got the government saying you've got a lot of documentation coding issues. So yes, we do need to query. And the fact in reality is that the clinical terminology that physicians may use and the classification terminology, that of ICD-10, CMPCS, and CPT, sometimes don't match up correctly. And so there's confusion. There may be a lack of specific documentation or no documentation to support the charges or the claims. The charges don't meet medical necessity or the documentation. Again, that conflicting, contrasting, ambiguous, nonspecific. And guess what? Our reimbursement systems here in the United States are code dependent. We're dependent on having these codes, whether it be CPT or ICD-10, available. And they need to be accurate so the reimbursement will be accurate. And then we have quality reporting, and that is becoming more and more code dependent. So again, if we want to reflect quality, and in the future more payment will be based on quality, we need to be very, very cognitive of documentation and coding accuracy. And certainly that goes along with our query process. And yes, we need to query because we want to have critical patient care to be accurate, risk management. Not all documentation sometimes is complete at the time of the encounters. We know sometimes it's less, although the EHR has helped improve a lot of that. We have the Joint Commission and Medicare who both require documentation to be documented for significance of abnormal test results. They have requirements of that, so think about that too. And then we have, again, that compliance piece, the fraud, waste, and abuse attention across the industry to try and minimize the payments that are inaccurate that the federal government, our tax-paying money, is covering and paying for. Also, we need to query because there is information that the OIG, the Office of the Inspector General, has provided some special reports to help guide us and tell us, in this area it doesn't look good and we need to improve ourselves. So use those OIG reports to identify, yes, there may be querying times out there too. The recovery audit contractors or our recovery auditors, of course. Even AHA coding clinic guidance has directions to query, and we should be following that guidance. We have MSDRGs, HCCs, greater coding specificity required in those, so documentation needs to be specific. And all of that comes together, and it certainly can be confusing at times with the different rules we have. There are also, right in the clinical documentation itself, sometimes there are risks. There are symbols being used, maybe pluses or minuses or arrows ups and downs, and we can't code from those, but they can cause risks to be out in the documentation area. And there could be a clinical situation, and we're seeking clarification in that particular arrows ups and downs. And there would be a terminology used or an acronym or abbreviation, and we see more and more of those acronyms and abbreviations being used. And do we have a true meaning of what that is? Does ETOH with a plus symbol mean the patient is an alcoholic, abuser, drinks socially, has a positive blood alcohol level? So that documentation can be risky. And there are codes for many of these signs and symptoms, but we have to be very careful about that assignment. So when we think about all that evidence and all those reasons why we want to query, we come back to the practice brief as the gold standard in the industry, something that we need to be sure that we're following and understanding and utilizing. So again, I say the reasons when and how to query are listed in the Achieving a Compliant Query Practice from 2016. And this is very valuable to you to follow. Now, all professionals are encouraged to adhere to these compliant query guidelines regardless, and this is really important, regardless of your credential, regardless of your role, regardless of your title, or use of any technological tools involved. We still have to be compliant with our query practices. We can't be gaming the system. We can't be leading diagnosis. We have to be very aware and be very compliant in this area. Sometimes I've heard individuals say, well, I have a credential of PhD after my name, so I don't have to follow these. Only those that have a CDI credential or anyone that has a CCS has to follow these, or a CPC, they have to follow those. No, it actually says in the practice brief, regardless of your credential role or title, if you're doing documentation improvement on any level, then this would apply to you. The guidance also addresses an area which has caused a little confusion, and probably in the future we'll have more clarification, but this is where we are now. The open-ended queries are preferred. Open-ended queries are preferred. Multiple choice and yes, no are also acceptable, but only under certain circumstances. And the yes, no query format should be constructed to include additional options associated with multiple choice queries like other, clinically undetermined, not clinically significant, and integral to. I see queries, and I can tell you in the last year, missing these latter choices of other, clinically undetermined. The choices are all those that result in reimbursement changes of moving up the reimbursement line. So we still have problems out there, and yes, there are pressures to obtain additional reimbursement and to cover costs in healthcare, but we must remain diligent to the compliance side. So remember and take a look at your queries, and again, this applies to verbal, verse, and written, to make sure that you're putting other clinically undetermined, not clinically significant, similar language. Also, in the guidance, the yes and no query may be used, as it said, under certain circumstances where only clinical indicators of a condition are present and the condition, diagnosis, has yet to be documented in the health record. New diagnosis and procedures cannot be derived from a yes or no query. And that gets sometimes a little hard and difficult and challenging, but you have to be very careful. And when you're thinking, well, can't I use a yes or no, maybe you should really try, can't I use a multiple choice? Maybe that would still work, because the yes and no really gets to be questionable at times, because the yes will typically lead, because it's a single yes or a single no, will lead the yes to a particular diagnosis that changes or increases the reimbursement. So it appears you're leading to that financial gain. So that's an area that you want to be very careful of. And whenever I'm saying, someone says, well, we have to use a yes or no, I'm thinking, well, can't we make it a multiple choice? So here's an example from the practice brief that is compliant. It's a yes and no. And notice they have other and clinically undetermined included. So yes, it is a yes or no, but it has two other options as well. Think about that in your yes or no queries. And all queries must be accompanied by the relevant clinical indicators that show why a more complete or accurate diagnosis or procedure is being requested. Think about that. You need to be able to tell the story of why I am asking this question. And the clinical indicators should be derived from the specific medical record under your review, the one we're reviewing and looking at, and that unique episode of care. And the clinical indicators supporting the query may include elements from the entire medical record, such as the diagnostic findings or provider impression. It may be on Tuesday's lab value. It could be on Thursday's progress note. It even could be from a dietary note that you want to correlate, or a speech therapy note that you want to draw attention to that had something that caused you to want to clarify with the physician. It could be a consultant report on a particular day that said something. And multiple choice query format should include the clinical significance and reasonable options as supported by those clinical indicators. There should be reasonable options. And I know that's come up on some questions too. Well, how do you make it a reasonable option when really you're thinking in your head only one thing is going to be relevant? So you have to think more broadly sometimes, even though you're trying to get to maybe a single choice. Now, providing a new diagnosis as an option in a multiple choice as supported and substantiated by the clinical indicators. So going back to the clinical indicators, and is not introducing new information because it's in the medical record. Multiple choice query formats should also include those additional options, again, clinically undetermined or other, and there should be an opportunity for the provider to add free text. That's another one I see missing. Sometimes in queries, I've had people email me and say, do you think this query is okay? And they're missing the opportunity for the physician to put anything they want, the provider, and they should have that other in an area for the physician to add something. So look at the complete practice brief. Make sure you're not leading to one particular choice, two particular choices, but have these additional options that would be clinically undetermined or other, and make sure there's a space or an area in the paper or electronic form that would allow the physician to add that information. Now, a little tip on anemia that's come up, that in a querying for anemia, anemia is not already documented anywhere in the health record. Then the written query should not be titled anemia, because what are you doing when you put that in front of the provider? You're introducing anemia. However, if anemia is already documented in the health record, then the written query may be titled anemia because you're seeking clarification of a diagnostic term that is already there. And multiple choice selection would be your best model of format. So think of your queries that you're using and other diagnoses and procedures and how you're wording them or titling them. Remember, the condition that you're seeking clarification on the query form for, if it's not already documented anywhere in that medical record, health record, then you shouldn't title it after that. I want clarification about respiratory failure. That's the title, and there's no respiratory failure anywhere in the record. So that's also an area where we have some risk and we want to be compliant. So think about those and take out your query forms, your communications, electronic or written, and see how they are designed and formatted and the language that you're using. So speaking about the forms, the query format, and you can use templates. I'm thinking most often when I think about a template that the top portion where we put the demographics, dear Dr. So-and-so, you have a space for the patient, you maybe have a space for the medical record number and the date. Those will always be similar. And even the bottom, who do you contact? We appreciate how you completed this. Thank you. You can contact us if you have any questions. That would always be the similar and same. But the middle part is going to be different. Every patient has different clinical indicators than others. So that part will be more designed, customized, depending on the situation. So the query form can and should be used to the extent it provides clarification and is consistent with other medical record documentation. It should be phrased such that the physician is allowed to specify the correct diagnosis. Remember, I mentioned leaving space for the physician to put in their own diagnosis, their own information about a procedure. We should always leave space for the physician, provider, to do that. It should not indicate any financial impact of the response, any. This will help get a better CPT code. This will help get an HCC. This will help change the reimbursement. This will bring $50 more. We shouldn't be doing those things to identify that. And I've even heard and seen compliance officers say that on your query forms, you don't even put weights. So the weights, as we know, and HCCs and DRGs indicate, obviously, and an RVU indicate payment. The higher those numbers, the higher the payment. So we shouldn't even be putting those on our query forms either. The form should not be designed so that the only thing is, please sign here, everything else is done for you. Now, the physician may like that because it's pretty easy to sign, but that is not appropriate. That is not compliant, and you should not be completing the query form yourself or your staff to do, and then just saying, please sign here. That is not legally ethical for you to do. So when querying, provide the objective clinical information from the medical record, that documentation is already there, Identify where in the medical record that is, so the date, the time of that information. It could be a lab value on a particular day. It could be a nursing note. It could be a consult. And reference that in your query, so you always leave space in there for that. Address the documents such as the progress note, nursing note, dietary note, the date the issue was found, and the physician will be cooperative. He thinks that the coding professional or CDI is trying to help them. And you must remain very positive and remember manners when you're phrasing things. You don't want to be dictatorial in your language to the provider. So think about your format. And also then think about how verbal querying. And this gets a little difficult because you want to make sure you have your script and your information. And I read an article recently, it was about 2 months ago, about a situation where there were federal investigators at a particular hospital, but they were looking for something other than querying and documentation. They were looking at something else, but they were observed and watched the interaction between the CDI staff and the providers, and they identified non-compliant leading exchanges. They were leading in the verbal querying, and that opened up an additional investigation on them because of that. So think about the verbaling process, and I know that's a little challenging because you want to have a nice casual conversation, but each verbal exchange needs to follow a script or follow that same format and be non-leading. And you need to track those queries that are verbal as well, and that'll be an important piece to do in addition. So think about that and think about the verbal querying process that may be out there. Another area to be compliant around is querying technology. And boy, this is really taking off, technology out there, especially since we've got the EHR, EMR out there for everyone. We now have the ability even to generate the query electronically, and physician groups and practices are connected to the hospital system so they can see the record, they can complete the record, and queries can be sent electronically. They'll appear in that inbox. It may be an inbox that the physician sits in his office and reads, or it could be that inbox while they're up on the floor, they're looking at the computer system patient record, and they can go in and see it. And we need to be careful there. They cannot lead. Also, computer-assisted coding, CAC technology, should not be generating leading queries. CDI technology, clinical documentation improvement technology, should not be leading and generating leading queries. All the technology tools, and there may be others than these that I've listed here, must follow the industry standards. So what does that mean? We need some oversight here, and I think more involvement, engagement by the HIM coding side to follow the ethical standards of querying and the query practice briefs. So this is an area where you want to think about that technology, and sometimes it comes to you as the employee and it's all a done deal. But there's errors and issues with it and concerns you've discovered. Take them back to your management and be sure to share that you've got issues and concerns and see if they can work out a corrective action plan to improve upon the technology or change it. But the best practice is when you're considering a technology, make sure you go through the trials and pilots and betas thoroughly to identify any issues around querying that the technology may have. Another area I wanted to mention is the AHA coding clinics, and here we are today with the AHA coding clinic sponsored educational program. There are several issues where we have good instruction guidance that we should be querying. In this one from 2000, if there is evidence of a diagnosis within the medical record and the coder is uncertain whether it is a valid diagnosis because the documentation is incomplete, vague, contradictory, it is the responsibility of the coding professional to query the physician. Also, in this one from 2002, we see that when the attending physician cannot confirm the results of the radiology for the inpatient coding, we query. So there is instruction and guidance in our coding clinic to query. Also, another place where there's instruction and guidance is in the AHIMA standard of ethical coding. In this document, in this guidance, there also is a section regarding querying. I'd suggest you get this if you haven't seen it before and look at it. In this particular guidance, there's a standard number 4 that addresses querying. And it says that querying and or consulting as needed with the provider for clarification of the clinical documentation prior to the final code assignment is in accordance with the acceptable healthcare practices is good. And in developing your query policy, so think about, do I have a policy around my querying? That would be important to have, to use this practice brief and the standards of ethical coding to help guide you. And they have a couple examples, designing and adhering to the policies regarding the circumstances when the provider should be queried. And in some situations, a query to the provider will be initiated and offered due to late documentation. And I think we'll all agree about that. But also there's some information under shall not, which is 4.4 and 4.5, important to recognize. The query the provider when there is no clinical information in the record that necessitates a query. Well, you shouldn't be querying them. And utilizing health record documentation from or in other encounters to generate the query. That should not be done. So those are some guidances that can be of value. Now, in the official coding and reporting guidelines, they also tell us about querying. So I did a word search on this document to find out when and if it tells us to query. You could do the same thing, and this is available free, the official coding and reporting guidelines. You can download them. Just take that title, ICD-10-CM Official Guidelines for Coding and Reporting, FY, fiscal year, FY 2018. You can download that. If anything is underlined, it means that it has been moved from the prior year, and if it's italics, it means that it is a revision, and if it's bolded in the narrative, it's a change. So in here, it does talk about the responsibilities of us as coding professionals and having great documentation. These guidances, of course, apply to all our settings. It will call out specific settings, different from inpatient and outpatient, but there's a lot that overlap and are the same. In the guidance, they do identify, and what I've done here is I bolded the word query so you can see in the guidances, here's some examples. Under Convention 13, if it is not clear whether the two conditions involving the excludes one note is related or not, you're supposed to query the provider. Under Guideline number 16, documentation of a complication of care, query the provider for clarification if the complication is not clearly documented. Number 17, for borderline diagnosis, whenever the documentation is unclear regarding the borderline condition, coders are encouraged to query for clarification. In Chapter 1, the specific coding guidelines around acute organ dysfunction, it talks about having, if the documentation is not clear as to whether the acute organ dysfunction related to the sepsis or is related to another medical condition, query the provider. So not surprising, we have these great specific instructions right out of the official coding guidelines to follow. Now, going back to AHA Coding Clinic, and documentation issues, it says from 2015, would generally be unique. We're not unique in ICD-10, so as long as there is nothing new published in the Coding Clinic, then that advice would stand. And so what we have in our coding querying, our CDI querying, it's a balancing act. It does take skill and knowledge to be able to query appropriately and know when to query and to make sure you have the ability to non-leading queries. So be sure to think about the compliance aspects of doing that and your responsibility as a professional from a compliance perspective to make sure you're being compliant with your querying. Also, what we can do is we can look at how we can engage our physicians. So awareness and education, more formal, but awareness is key, to be aware that there is issues with some documentation. Why are queries even used? Sometimes physicians don't realize that. So we need to first start with that awareness of explaining why would I query a physician or why we would. And outline the process. So we're getting a little more formal here, but when you outline the query process of how and when and what the time frame and expectations are, that's engaging to the physician to understand they're linked to the important issues around querying to represent the patient care, the quality of care. So explain to the physician that we would like a query policy and procedure. Would they like to go over it with you? This might be a physician that's a physician champion, someone who works with either case management or maybe CDI, depending on how large your organization is, maybe a dedicated physician who would be engaged to help with this. And they can provide examples, and that would be ideal to hear about their situations. Emphasize that documentation improvement aspect of how the query may be a learning tool for physicians to be aware of the necessary information of documentation. A lot of it they're not taught about in medical school, and so they need to know about the needs of the codes and the documentation so that we can truly reflect the patient care and demonstrate the picture of patient care. Now, encouraging physicians to document when conditions are being empirically treated, the diagnosis resolved versus are ruled out. That would be addressed in your communication to your physicians or your education. The interaction between disease process and why that's important to document. The possible probable scenarios and why in the inpatient setting it's different at the end of the stay versus on the outpatient where we don't apply that rule. The reasons for the patient staying longer or retaining longer. It could be in observation. It could be longer in an admission in a hospital. There are clinical concerns regarding a particular patient and any uncertain diagnosis, and promote an open dialogue around this will be key. Having your policy and procedure, I alluded to having that, that's very important. So physician querying and follow that practice brief to set up your policy and procedure. That's the gold standard. Have an area in your policy that talks about the query wording and the format in non-leading. Talk about in your policy the retention of queries. Nothing to hide, then they should be available. And monitoring and tracking your queries. This can be very valuable to see if there's a particular diagnosis or procedure that is problematic, or a particular physician that just doesn't seem to be aware of a particular issue around certain wording. So you'd want to track that physician, tracking who the physician is, or the particular diagnosis or procedure that you're querying on all the time. You also want to have a policy and procedure around education around querying, including the CDI and the physicians or others. And make sure your policy around querying is for all payers and all settings, not just Medicare. And that's a big one out there too, is that a lot of times CDI or coding queries are just isolated to just the Medicare payers or even just Medicare Advantage. And we need to make sure all settings, not just inpatient, but outpatient too, and all of our payers. And also incorporate that directly into any CDI policies and procedures around querying. You should have that in place as well. So if you have CDI doing activities, do you have written policies and procedures? If the answer is no, then you need to go back to the drawing board and look at that. Follow that practice brief for your CDI and address both written and verbal querying that you would utilize in CDI. When and how that you would query. Put some examples in your policy and procedure. Also, build a quality assurance process of validating that the queries are good. They're compliant. They're non-leading. So you need to have a check or an audit process of the querying. If you haven't done that, you need to. From a compliance perspective, this is really important to have in place. And don't single out just one payer again, even for your CDI activities. That would be an area of concern. So I mentioned that quality assurance review process, and so here's a little more information about that may be helpful to you if you haven't done or had your querying or your CDI process looked at. This would be something that's done fairly regular, maybe twice a year, It really supports the compliance, and it can be both random and focused. So first of all, you start out very random, just look at a group of 100 encounters or 100 inpatient records and look at the queries that were used on those. And then more focused, based upon the results, the second time you do a QA review, you would look at the most focused area where you had problems that you identified in the random, and then discuss those. Review those with the coding and CDI staff. You're checking for the appropriateness of the query, the non-leading wording and format, missed opportunities, overutilization of querying, and trending all the results over time. So give feedback to your CDI staff or your or your coding staff on what they found. Have an open dialogue. And I know sometimes that feels uncomfortable, but it's really important that you have that feedback loop. Make changes in your forms and your processes. Annually review your policy and make changes to that. If you have templates, check those out each year. And education and awareness should be continuous, with dialogue being very open. So as we look at and talk about the documentation around querying, unclear documentation can occur when a physician suspects a condition and maybe documents it even initially and rules it out mentally while they're treating the patient, but fails to document that it's been ruled out. So sometimes that can be confusing. You need to find out if that condition was ruled out. It looked like at the beginning, when the patient was admitted through the emergency room in the first day, that certain condition was present, but after, nobody mentions it anymore. So then there's a query opportunity. The physician documentation should describe the patient's condition using terminology that includes specific diagnosis as well as the symptoms, the problems, and the reasons. When you look at physician documentation, that we often focus around diagnosis, but in the broader picture, there can be evaluation and management discrepancies that appear on the documentation. So there could be other things besides diagnosis. Your query process should be in place to assist obtaining accurate and specific, complete, truthful documentation. And remember that the documentation, of course, supports the code and the claim data. And if that is not accurate, then the claim data would be inaccurate and compliance risks involved. This little example is from an office encounter note and just shows a little bit about the documentation areas. There's the E&M, there's the physician notes, there's the consult, you can have discharge summaries, you can have H&Ps, progress notes, MD orders, and a lot of different things can appear in a note. So documentation can be, again, from the provider, incomplete and imprecise, and we would query them and have them then respond back following the AHIMA practice brief. Do not instruct to query the physician. They do instruct to query the physician in our coding clinic, and we want to make sure that our diagnosis is medically necessary and meets those goals too, because that comes up as a lot of denials, especially in the ambulatory setting. So what are our next steps? Know the query practice brief guidance. So we didn't go over the whole thing today. There's a lot more there to talk about. Develop policies and procedures, but follow the practice brief as a guide for your policies and procedures. Perform query reviews and audits and track and trend them over time. Solicit feedback and have an open dialogue. Work together, CDI and HIM coding. Annually review your policy. Annually review your query forms and templates. Provide education and feedback. And build these steps into your successful compliant query activities. So in summary, queries are definitely an essential tool in our healthcare picture and really tell us what was done to the patient encounter, what was the medical decision making. They support compliance. Yes, they support reimbursement and quality improvement. So we want to make sure our documentation from our physician providers really shows us the patient diagnosis and treatment, that we need to have a QA process in place for CDI and HIM, and we need to look at the industry standards, the different practice briefs that will help us to be successful and to be compliant. And now we'll go to our question and answer period. And Brandon, do we have any questions from our attendees?
Yes, ma'am. Thank you, Gloryanne. The first question we have is, how do we handle issues with querying between the CDI staff and coding staff?
Well, the first thing by that question, I'm thinking it's probably a little confrontational is why they're asking that, issues with querying. So the first thing to do is to agree, get the two groups to agree. We don't want to have confrontation. It should be a non-confrontational dialogue. Both groups and both parties, both professionals, bring something of value to the table to discuss. So arrange to meet and discuss their concerns. Utilize the official coding guidelines, utilize the practice brief, utilize AHA Coding Clinic to help direct and locate a reasonable solution to the problems. Continue to meet every 2 weeks or at least at a minimum monthly to continue that open dialogue would be ideal. Thank you. Brandon, the next question.
Thank you. And the next question is, when querying the provider, should we have templates already created?
Now, I talked about that a little bit. It is acceptable to have a format that is consistent. The clinical indicator information, of course, will be different, where they found the lab information, where they found a particular progress note, and the multiple choices will be different depending on the diagnosis or the procedure that you're clarifying. So the top portion with the demographics would be similar, so that would be templated. And the bottom portion, you're probably going to have your logo on there. You'll have your department information at the bottom. Contact information is very, very important. So yes, you can have these templates that are similar, but remember that every patient is different. So the clinical indicator portion may be different, and we'll have different diagnoses and procedures that we'd want to clarify. Next question, Brendan.
Thank you. The next question is, does the querying practice brief and requirements apply to physicians who also query other physicians?
Okay, yes. The role of the individual or the group is to review the documentation and query the provider. Then they are performing the task and meeting the definitions of the practice brief. Yes, it applies to them. So it doesn't matter what their title, and we all have creativity with our job titles, don't we? It doesn't matter what your title is or what your credential is. Even an MD, they must follow those standards. Good question. Thank you. Any other questions?
Yes, ma'am. The next question is, when using electronic querying forms templates, should these be checked for compliant with practice brief also?
Yes. Yes, you should take those query templates and forms and check them against the practice brief, absolutely. And if you're using technology for these, make sure your technology gets updated. So sometimes we say, oh, this isn't good, let's fix the wording here. So we fix it, but do we do it everywhere that appears? Technology today, you need to be diligent and ensure that the technology that you're using for query templates and query forms and the query process is compliant. And don't forget that if you have other questions that come up today, that Coding Clinic Advisor website, you can submit a question there. Brandon, any other questions?
Yes, ma'am. The next question is, where do you recommend that queries are retained, in the medical record or elsewhere?
And I know they just said, what do you recommend? My personal preference is that if it is labeled as a part of the medical record is ideal. I always take, and I remember an attorney telling me that, a compliance attorney telling me this, do we have anything to hide? And I said, no, we don't. The queries are non-leading. We're doing a great job of reviewing them every year. Then we keep them as part of the medical record, and our policy reflects that, and the form reflects that at the bottom, that this is a permanent part of the medical record. Now, some organizations feel differently, and I think there's less of that than there is more. But when they don't keep them, then you need to keep them someplace else to have them as evidence. Destroying them or eliminating them is not a good practice. Next question.
Yes, ma'am. The next question is, what tips do you have for assuring over-compliance departments that the CDI are following both the written and verbal coding guidelines?
So if I understand the question, the compliance department to oversee CDI or coding on the querying, first of all, my compliance department might have then included in their annual auditing or reviewing process a review of the querying and the policies and procedures of both those departments annually. So they would be on the list for my compliance activities for the year if I was a compliance department. And if I don't have the time or the staff to do that myself within my compliance department because I'm small, I might hire an external review to do that. And there are companies out there that could do that kind of work, review, and that's the scope of the work, is to review the queries and the query process utilized by coding and CDI. Thank you.
Thank you. If we didn't get to your question, please submit your questions to AHA Coding Clinic via www.codingclinicadvisor.com. Please make sure to fill out the survey for the webinar to receive your CE form for the AHIMA and AAPC. Thank you, and have a great day.